Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO.
Hi, listeners, and welcome back. Today, we're going to take a deep dive on emergencies related to chemotherapy. In a later episode, we'll discuss surgical emergencies, including management of VTE and other cancer-related medical emergencies. If you want a more general review of toxicities of chemotherapy classes or specific drugs, take a listen to our chemotherapy episodes. There's lots of info in those. Sydney, what are our learning objectives for today?
Today, we're going to explore the types of infusion reactions, presentation, and management, review the definition and management of febrile neutropenia, discuss drug extravasation, risk categories, short-term and long-term management, review the prevention and management of hemorrhagic cystitis, discuss management of hematologic toxicities, including growth factor support and dose reduction, and briefly review other emergencies related to cancer, mainly therapy related.
Let's jump into it. Hypersensitivity to chemotherapies or infusion-related reactions to the formulation or solvent are not uncommon, so knowing how to identify and treat them is really important. These can be hypersensitivity reactions, which are allergic and IgE mediated, or anaphylactoid reactions, which are not mediated by IgE. These can occur with administration of any agent, although some are more likely than others, as we'll review here. Reactions can include, in order from least to most severe, fatigue, myalgias, fever and headache, rash, urticaria, pruritus and flushing, nausea, vomiting and abdominal pain, dyspnea, throat irritation, laryngeal edema and bronchospasm, and dizziness, hypotension, and tachycardia. Generally, immediate reactions, about 5 to 10 minutes in, are in response to the diluent or formulation, versus later onset reactions like 30 minutes or more, which are true hypersensitivity to the drug. However, there is some overlap. Both cisplatin and carboplatin are immunogenic and can cause an IgE-mediated anaphylactic reaction. The risk of reaction increases with increased cumulative exposure. In fact, up to 20% of patients will have an infusion reaction after 8 cycles of platinum. Other common offending agents include paclitaxel, docetaxel, etoposide, and topotecan. Taxane hypersensitivity reactions are thought to be related to cremophore, the solvent used, and they typically occur immediately during the first or second exposure. Generally, premedication with corticosteroids, H1 and H2 blockers are recommended and should be given at least 30 minutes prior to infusion for prevention of taxane reactions. If a patient has had a prior reaction, these meds should be given for 24 hours prior to desensitization.
It's important to try to differentiate symptoms of an immediate infusion-related reaction from those of hypersensitivity as management differs. The most common offending agents for an infusion-related reaction are paclitaxel, again from the cremophore diluent, docetaxel, liposomal doxorubicin, and rituximab. Common symptoms and signs of an infusion-related reaction include a sensation of a hot seat, a pressure or heat sensation as if the patient needs immediately to urinate, flushing, chest pain, abdominal or back pain, increase in heart rate, or a change in blood pressure. One of the key differentiating factors between infusion-related and hypersensitivity reactions is that an infusion reaction symptom will improve and resolve once the chemotherapy infusion is stopped. In a hypersensitivity reaction, signs and symptoms typically continue and even worsen after the chemotherapy infusion is stopped. At the time of a reaction, it can be difficult to differentiate between the two, so if there's any uncertainty, a reaction should be managed as a true hypersensitivity. Treatment of infusion-related reactions consists of stopping the infusion, giving additional doses of IV antihistamines or steroids, waiting 30 minutes to an hour until symptoms resolve, and then re-challenging by slowly increasing titration of the infusion rate in 15-minute intervals as tolerated. For paclitaxel infusion reaction, it's recommended to switch to an alternative therapy. Albumin-bound paclitaxel, also known as Abraxane, is preferred by the NCCN guidelines as an option for future chemotherapy. You can also consider trying docetaxel. However, patients may also have a reaction to the polysorbate 80 used as a solvent in docetaxel. Treatment of hypersensitivity reactions is pretty formulaic. Firstly, and most importantly, stop the infusion. Confirm that the pump has been turned off. Secondly, assess your ABCs: airway, breathing, circulation. Apply oxygen. If there's a severe anaphylaxis or angioedema, IM epinephrine should be given. Give Benadryl 50 milligrams IV for H1 blockade, 20 milligrams of famotidine IV for H2 blockade, and IV normal saline bolus for blood pressure support. Next, give corticosteroids, dexamethasone 20 milligrams IV, methylprednisolone 125 milligrams IV, or hydrocortisone 100 milligrams IV. If the patient still has symptomatic wheezing, give nebulized beta agonist bronchodilators. The patient should be observed for 1 hour or more before going home. If symptoms are worsening or persistent, give another 20 milligrams IV dexamethasone or corticosteroid equivalent. It's a good idea to call your rapid response team, as they may need continued support. The patient is done with chemo for the day. Do not rechallenge. Patients who have mild reactions can be rechallenged in 3 to 5 days' time using a desensitization protocol. This involves a 4-bag protocol with simple dilutions from the original bag, 1 to 1,000, then 1 to 100, then 1 to 10, and finally 1 to 1. Each bag is given over 1 hour, with the exception of paclitaxel, which is 3 hours per bag. Desensitization protocol should be done with a 1-to-1 nurse staffing with pre-placed orders for management so that a nurse may immediately proceed with interventions at bedside if needed. If a patient developed a severe anaphylactic reaction as evidenced by hypotension, systemic urticaria, or has been intubated or required a code, they should not be rechallenged in the future, and referral to allergists is recommended. If the reaction was to paclitaxel, albumin-bound Taxol can be a potential alternative. However, there is a risk for a repeat anaphylactic reaction to this new drug. These patients should be referred to an allergist for workup prior to making this decision. There's an excellent one-page reference on the SGO ConnectEd website for management of chemotherapy hypersensitivity reactions and desensitization that we encourage you to print for reference. A link can be found in our show notes. Additionally, there are algorithms from the NCCN and ASCO to guide choice of agents for rechallenge.
Next up, let's talk about febrile neutropenia. It's defined by the Infectious Disease Society of America as a temperature greater than or equal to 38.3 Celsius or 101 Fahrenheit one time, or a sustained temperature of greater than or equal to 38 degrees Celsius or 100.4 Fahrenheit for an hour, plus an absolute neutrophil count of less than 500, or an absolute neutrophil count that is expected to drop to below 500 in the next 48 hours. Neutropenia in the absence of fever is defined as an ANC less than 1,000, severe if it's less than 500, and profound if it's less than 100. 500 is used as the cutoff in neutropenic fever, as the risk of clinically significant infection rises at this point. Notably, the risk also rises when the neutropenia is longer lasting, like more than 7 days. The risk of bacteremia specifically increases when the ANC is less than 100. Patients on glucocorticoids or those who are immunocompromised may have reduced ability to mount a fever. So signs of SIRS like tachycardia, tachypnea, and hypotension with neutropenia should raise concern for neutropenic fever, even with a normal temperature. Early identification is paramount. Mortality ranges from 5 to 20% and climbs to 50% in patients experiencing shock. Febrile neutropenia can be due to a bacterial or fungal source. It should be a goal to obtain blood cultures before you get antibiotics started, but don't delay your antibiotics for this reason. There's evidence that antibiotic administration within 30 minutes of presentation improves survival rates. Empiric therapy with an anti-pseudomonal beta-lactam is preferred. Check your hospital antibiogram to determine which is best. If MRSA is likely, add vancomycin. After antibiotics are started, assess the clinical status to determine the patient disposition. Can they go home? Do they need to be admitted? Do they need to go to the ICU? You should do a thorough diagnostic evaluation, including a full exam, labs, and imaging to attempt to identify a source of infection. So, Sydney, febrile neutropenia is always serious, but when does it tip into an emergency? How do we know when to admit patients to the hospital?
Great question. Validated scoring systems exist to help triage, such as the Clinical Index of Stable Febrile Neutropenia, CISNE, and the Multinational Association for Supportive Care in Cancer, the MASCC, Index for Febrile Neutropenia, both of which can be found online. If patients meet any of the following criteria, they are classified as high risk and generally recommended for inpatient management. Neutropenia suspected to last greater than 7 days. If they have a MASCC score of less than 21 or a CISNE score greater than or equal to 3. If there are signs of severe sepsis or septic shock, mucositis that interferes with swallowing or causes severe diarrhea, GI symptoms, intravascular catheter infection, new pulmonary infiltrate or hypoxemia, underlying chronic lung disease, cancer that is progressive after 2 cycles of chemotherapy, hepatic insufficiency being AST or ALT greater than 5 times the upper limit of normal, and or renal insufficiency with a creatinine clearance of less than 30. If deemed safe for outpatient management, close follow-up is needed. Patients should be evaluated daily in the first 72 hours, return if they develop new signs or symptoms, or if they have persistent or recurrent fever after 3 to 5 days. As for use of granulocyte stimulating factors during an episode of neutropenic fever, it's controversial. The Infectious Diseases Society of America recommends against it. However, the American Society of Clinical Oncology, ASCO, and the NCCN guidelines state that they can be considered for patients at high risk for infection-associated complications or patients that have factors predictive of a poor clinical outcome. As for the length of antibiotic use, if you find a source of infection, then treat the infection as dictated by the site and the infectious agent. If you don't, then continue empiric antibiotics until at least the patient is afebrile for 72 hours and no longer severely neutropenic. The decision of when to stop antibiotics may be institution specific, depending on the ANC. That's it for febrile neutropenia. Maya, want to tell us about drug extravasation?
Yes. Extravasation is the leakage of fluid or medication from a blood vessel into the surrounding tissues. Degree of concern is dependent on the character of the infused substance. Vesicants are highest risk, followed by irritants. Vesicants have potential to cause blistering, severe tissue injury, and/or tissue necrosis. Offending agents include doxorubicin, actinomycin D, cisplatin at some concentrations, trabectedin, and vinorelbine. Irritants can cause a localized reaction, including aching, tightness, phlebitis, and inflammation. These don't cause tissue necrosis unless there's severe or untreated extravasation. Drugs in this group include carboplatin, gemcitabine, liposomal doxorubicin, bleomycin, etoposide, ifosfamide, and topotecan. Paclitaxel and docetaxel are irritants with some vesicant-like properties. The complications can be severe, so some providers advocate for central venous access via Mediport for patients being treated with a vesicant, especially for doxorubicin. Early signs of extravasation include discomfort, burning, erythema, leakage from the IV site, or slow infusion. Later signs include more severe pain, swelling that progresses to blanching or blistering, discoloration, and/or necrosis. Severe extravasation events with a vesicant can lead to the need for debridement, skin grafts, or even amputation. A referral to plastic surgery is reasonable at the time of event. Debridement is often needed for pain or unresolved tissue necrosis that persists longer than 10 days. Should you notice any of these signs, stop the infusion immediately, keep the cannula in place, and aspirate the extravasated fluid. Don't flush the line, as it can push the vesicant further into the tissues. There are specific protocols and antidotes per drug, which are likely in your infusion center. If you need a reference, look up Table 12.2 in the Principles of Antineoplastic Therapy, 4th edition, published on SGO ConnectEd.
Next up, we've got hemorrhagic cystitis. Cyclophosphamide and ifosfamide are the typical offending agents. They are prodrugs which undergo hepatic metabolism into active alkylating agents. During this process, acrolein is generated as a byproduct. It is excreted in the urine and directly damages the bladder mucosa. Prevention is the name of the game here. IV hydration should be given 12 to 24 hours before treatment and continued for 24 to 48 hours after, at a rate of about twice maintenance. You can also encourage oral fluids. Mesna, sodium 2-mercaptoethane sulfonate, is co-administered with cyclophosphamide or ifosfamide and then again 2 and 6 hours later. It binds to acrolein in the urine, neutralizing its toxic effects without affecting the anti-tumor activity of the chemos. When hemorrhagic cystitis is severe, it can cause anemia and precipitate clot formation within the bladder, leading to bladder outlet obstruction. In these cases, consult your urology colleagues and consider continuous bladder irrigation with a large bore 3-way Foley with saline. Next up, severe hematologic toxicities. How low is too low?
Management of myelotoxicity depends on the agent being used, as well as some institution-specific practice patterns. Let's talk about anemia first. The presence of anemia in cancer is multifactorial. It's both a function of the cancer itself and the chemotherapy that's given. Anemia is associated with worse overall survival in many solid tumors. We think this is because many of the treatments for cancer rely on oxygenated tissues to have the best benefit. Generally, any hemoglobin less than 7 is recommended for transfusion, and a hemoglobin greater than 10 is not. In between is murky and depends on a confluence of factors, including symptoms, active treatment, relation to surgery, etc. Erythropoiesis stimulating agents are no longer recommended or used. They've been associated with an overall increased risk of death, MI, stroke, and other cardiovascular events. In some oncologic randomized controlled trials, they were also linked with disease progression and overall survival. What about thrombocytopenia?
Thrombocytopenia, defined as platelet count less than 150,000, is something we commonly see because it's a side effect of some of our most commonly used agents, namely carboplatin and PARP inhibitors. If a patient is bleeding or planned for an open procedure, they should be transfused with platelets to keep counts greater than 50,000. If patients have disseminated intravascular coagulation, DIC, or intracranial bleeding, the transfusion threshold increases to 100,000. Lastly, if a patient has a platelet count less than 10,000 in the absence of bleeding or aforementioned situations, they should be transfused as there's an increased risk of spontaneous hemorrhage. Thrombopoietin receptor agonists, TPORAs, are controversial. They can be considered for chemo-induced thrombocytopenia, but they aren't FDA approved for this indication and may have an increased risk of VTE. If it's something you're considering, make a referral to hematology. Best practice is to only use enough of the agent to keep the platelets greater than 50,000. Chemotherapy also puts people at risk for leukopenias. Management and prevention of these with growth factors is recommended in certain scenarios. Specifically, NCCN, ASCO, and EORTC recommend GCSF prophylaxis if the risk of developing febrile neutropenia is greater than 20%. This is usually not done with the first cycle of chemotherapy, but is done in subsequent cycles after a patient has had an episode of neutropenic fever or had delays due to neutropenia. Filgrastim, aka GCSF, TBO filgrastim, pegfilgrastim, and others are FDA approved. The most frequent toxicities are mild to moderate bone pain, which can be managed with NSAIDs and antihistamines if refractory to NSAIDs. Rarely, these can lead to splenic rupture or increased risk of bleomycin pulmonary toxicity.
Dose reduction is another management strategy for myelosuppression. When considering this, think about the evidence in that disease with that agent regarding the importance of dose intensity in overall survival. In some disease sites and agents, this is more well established than others. There are guidelines for each drug on how and when to dose reduce for all kinds of treatment-related toxicities. These are likely built into your EMR and are standardized at institutions. As an example, for carboplatin, dose reductions are recommended if platelets are less than 50,000 or if the ANC is less than 500. And for paclitaxel, dose reduction is recommended for ANC less than 500 lasting for 7 days, and holding a dose is recommended if the ANC is less than 100. Sydney, can you walk us through the diagnosis and management of SIADH?
SIADH, syndrome of inappropriate antidiuretic hormone secretion, is a condition where the body produces too much antidiuretic hormone, aka vasopressin, leading to excessive water retention and low sodium levels. It can occur as a result of platinum compounds, alkylating agents such as ifosfamide and cyclophosphamide, and vinca alkaloids. Labs will show a sodium of less than 135, decreased serum osmolarity, in concentrated urine. Patients may have GI or neurologic symptoms. The management includes fluid restriction and slow correction of serum sodium. Remember that you can consult your subspecialist for tricky cases.
The last thing we should mention for chemotherapy emergencies is considering drug-drug interactions. Most documented drug interactions with chemotherapy are not serious or life-threatening, but you should pay attention to the metabolism, especially in those with hepatic or renal impairment. Okay, that's all we have for you today. Here are our takeaways. Drug reactions can be IgE-mediated or anaphylactoid reactions that are not IgE-mediated. Prevention of infusion reactions includes premedication with steroids and H1 and H2 blockers. Treatment includes immediately stopping the infusion, assessing respiration and hemodynamics. If there's severe anaphylaxis, administer epinephrine and call a rapid response. If there's a more mild reaction, give IV Benadryl, IV Pepcid, IV fluids, and IV corticosteroids. Patients should not be rechallenged with a drug that they've had a severe reaction to, but desensitizing or rechallenging can be considered for more mild reactions.
Although definitions can vary, febrile neutropenia is generally diagnosed in patients with an ANC less than 500 and a fever greater than 101 Fahrenheit on one occurrence or a greater than 104 Fahrenheit fever sustained. For patients on steroids, they may not be able to mount a fever response, so this diagnosis should be considered if that patient is presenting with SIRS criteria. It's imperative to get multiple blood cultures before initiating treatment and to initiate broad spectrum antibiotics within 30 to 60 minutes of presentation. Risk assessment calculators can be used to help triage patient disposition.
Anemia, neutropenia, and thrombocytopenia are all common occurrences in the management of gynecologic malignancies. Anemia is generally managed with transfusion, and erythropoietic stimulating agents are avoided as evidence has linked them with increased mortality. Thrombocytopenia is also generally managed with transfusion and/or dose reductions or delays of chemotherapy. Neutropenia more commonly is managed with growth factors, which can be used prophylactically or as secondary prevention after patients have significant neutropenia with the chemo cycle. Dose reductions and delays of chemo are also reasonable.
Many drugs used in gynecologic cancers can be irritants or vesicants when delivered IV. Doxorubicin is one of the most strongly associated vesicants and should generally be administered through a central catheter. Reactions to irritants and vesicants can range from localized pain or phlebitis and inflammation to skin necrosis and sloughing, which can require surgical debridement and tissue grafting. If an extravasation is suspected, the infusion should be stopped, the cannula left in place. The line should not be flushed. Check for specific antidotes depending on the drug in use.
Hemorrhagic cystitis is a potential complication of ifosfamide and cyclophosphamide administration. Prevention is via IV hydration before and after chemotherapy, as well as administration of Mesna. Management of hemorrhagic cystitis includes serial labs and transfusion as needed, continuous bladder irrigation, which can help evacuate clots and prevent bladder outlet obstruction.
Other chemotherapy-related emergencies can include things like SIADH and drug-drug interactions. More to come about medical-related emergencies in cancer.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at Ready, Set, GYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson. We'd like to thank Dr. Catherine Zong, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.